Thank you, everyone, for joining the Doc Shop Pro webinar this evening. A few housekeeping notes while folks are still getting set up. Everyone is muted. Questions can be submitted as we go, and you can utilize the chat on the right throughout. This webinar will be recorded for future distribution. Tonight's topic is diabetic foot ulceration and nudge theory. Leading us this evening is Dr. Josh White. But first, for those not familiar with us, Doc Shop Pro is a one-stop platform for your office. You can use our platform to cross-comparison shop for daily supplies, find ancillary products and capital equipment. You can utilize our partner programs, or we can even help you find new patients. With our My Supply Manager, we can help you take the process of reordering supplies, including brand names and generics, across dozens of vendors and manufacturers, and transform that into something you can do in single-digit minutes. Almost always, we can save you money along the way. Doc Shop Pro is designed to be plug and play for workflow and staff changes at your office. Registration is free. We can perform a free cost analysis anytime. We're here to help you save money, time, and to help independent practitioners remain independent. This evening, we're joined by Dr. Josh White, a podiatrist and certified podorthist who's vice president of OrthoFeet and has long combined interests in foot care and shoes. Selected as one of the most influential podiatrists in the U.S., he created SafeStep, which offers a proprietary web-based program for streamlining shoe ordering with guaranteed assurance of Medicare compliance. Dr. White serves as an American Podiatric Medical Association committee member that addresses matters relating to durable medical equipment. He's a coating line expert panelist. He's also a three-time Ironman triathlon finisher. We're honored to have him with us. And with that, Dr. White, the floor is yours.
Good evening, everybody, and thank you. And glad to have this opportunity to share with you some bits that I hope will be of benefit in your care of patients with diabetes and in your treatment of their people with diabetic ulceration, and most importantly, to use a term popularized by Dr. David Armstrong, keep them in remission. And I think that it is a very helpful way of keeping the diabetic foot ulcerations in perspective, because it is a ongoing battle to keep them from occurring. And so the things I'll be sharing with you are very much not what is taught in the podiatry schools, but are things that I have learned and have been helped by a lot of things that are currently in development utilizing new technology. I find it very helpful to be familiar with some of the research that's out there, both particularly with regards to helping patients with diabetic foot ulceration to have a full and appropriate appreciation for the risk that they are at. But first, just to, I guess, for your perspective, a refresher of how big a problem this really is. So, people with diabetes. People with Medicare, let's say about 6% of people with Medicare incur a diabetic foot ulceration, and so of those, say 1 in 20 who develop an ulcer, very few, I think, have an appreciation that once they have been successful at going through a course of healing, that there is unfortunately nearly a 50%, a 40% incidence of recurrence. So I think if there are a few things that I hope that you take from this presentation, that would be one of them. That right now, even though we are experts at wound healing, we overall, I'll just say, people who heal ulcers are not experts, or patients are not experts at keeping them healed. So this incidence of recurrence is nearly 50% within a single year. 5% of patients with a diabetic foot ulceration, again, require an amputation within a year, 1 in 20. So again, people who develop a wound are at tremendous risk, even once they have healed it, of developing it again. And people who have developed a wound are now 1 in 20 chance of incurring an amputation. 5% more, here's another study, even worse, 5% mortality within 12 months and nearly 50% mortality within 5 years. Again, there's a benefit to scaring the heck out of patients who have developed a wound, both in terms of getting their buy-in with regards to doing what's needed to heal it, and even more significantly, once it has healed, for them to appreciate that they are far from out of the dark, that there is just statistically a great chance of them developing the same problem or worse all over again. The 5-year survival following a wound is only 50 to 60%. So again, develop a wound, only 50%, only half the people even live for 5 years. Again, very impactful statistic to have at your ready and to share with your patients. Develop a wound, there's a 50% chance that you won't be alive in 5 years. Now, podiatry stands at a very, very impactful position with regards to our current health care economics. We are continuing to evolve. There is a continued evolution of our healthcare delivery system, evolving from one based on paying people based on what they do to, we call this fee for service, to one that is increasingly recognizing the value of keeping people from incurring costs. I might say, fortunately for podiatry, we are good as a profession at treating patients with diabetic ulceration, and good for us, there is a increasing number of people with diabetes who are developing ulceration. I say this is good for us because this is an expensive problem that we are good at solving, at healing, and I want to help you to become better at preventing the recurrence. There are a lot of studies that describe how much it costs on average to heal a wound. The number that I use to keep it simple is $10,000. So the average cost to Medicare to heal a wound is about $10,000. If that wound is to go on to amputation, foot level, here's this one study that shows about $43,000, and above the ankle, $66,000. So you might think about, should it go on to amputation? We're talking about a $50,000 cost. A little earlier, remember, we were saying there's a 1 in 20 chance of there being a $50,000 cost associated with that wound. So payers own that responsibility, and payers have a vested interest in avoiding those kinds of costs. And podiatrists stand in a very, very important position with being able to mitigate that financial exposure. We learn in school about the biomechanical etiology, and quite frankly, the biomechanics for healing a wound are very straightforward and not that complicated. But just as a review, the concepts, to be familiar with the concepts upon which the treatments are predicated. Wounds result from repetitive stress, and it's the combination of pressure and friction that we refer to as shear. That is the principal etiology of diabetic foot ulceration. Prolonged pressure, and to quantify the amount of pressure that is said to be dangerous or able to cause the skin to break down, is described as greater than or equal to 6 kilograms per centimeter squared. And we know that footwear or protection of the bottom of the feet is significant for being able to dissipate plantar pressure and prevent the foot from developing ulceration. The ways that the biomechanical principles that apply to the prevention of foot ulcers and how shoes relate have to do with the fit of the shoe accommodating or matching the shape of the foot, spreading the plantar pressure out so that is distributed over as greater a surface area as possible, reducing the shear pressure, meaning the amount of friction between the foot and the plantar surface. Rocker bottom soles are a therapeutic modality that enable the foot to roll forward without necessitating the amount of dorsiflexion of the forefoot. Bending at the ball causes plantar flexion of the metatarsals, causes increased pressure beneath the foot as it rolls forward. The rocker bottom sole allows the foot to roll forward, maintaining a normal heel-to-toe pattern of gait without the concomitant increase in plantar pressure associated with heel off. And finally, shock attenuation. So, the foot hits the ground during walking with twice the body weight. Cushioning is good and helps to, again, attenuate the impact that can result in ulceration. So it's these combination of factors that are utilized, whether it be by the combination of shoes, insoles, and socks to help reduce plantar pressure and thus reduce the likelihood of plantar ulceration. The gold standard for healing, or the gold standard for healing plantar ulceration is based on, again, the elimination of plantar pressure, and easier said than done because patients tend not to be compliant. The gold standard remains the total contact cast. However, surveys of practitioners reveal that only in the neighborhood of 2% of practitioners utilize this gold standard modality. Fortunately, studies have revealed that what's referred as an instant total contact cast, a clamshell type walker that can be modified with fiberglass casting sock to prevent its removal, can have, with an accommodative insole, can have nearly as good of an outcome. Again, it's the preventing the device from being removed and allowing thus allowing the patient to walk without the plantar protection that has been determined to be quite significant in its overall efficacy. So while patients would certainly prefer, if they were to be prescribed and are compliant with wearing a walking boot, would tend to prefer the ankle high type. That style has been demonstrated to be not nearly as effective as one that comes over the calf and is better able to transfer the plantar pressure further up the limb. Frequently, I'm asked for documentation to support the use of shoes, and unfortunately, people sometimes get the experience or have the experience that shoes don't work at helping to protect the feet. Well, the bottom line is that there are studies out there that do show their efficacy, and that the bottom line is that shoes can only work so long as patients wear them. Okay, but one study here, this is one that's probably quoted the most, is that foot ulcer recurrence was halved after a year. Okay, and so remember we said before about half of them come back, but in this study, patients wearing shoes, only in the neighborhood of a quarter came back. So again, it's not a cure, but having the risk is certainly significant. The recommendation associated with this other study, again, the conclusion was that shoes work, but that they need to be worn all the time that people are walking in order to have their therapeutic benefit. Now we get into the psychology part of being a good wound prevention expert, and this is where we get a bit into the psychology of what it takes for shoes to work. I have found that when a doctor prescribes a treatment that is perceived as necessary, patients will do what the doctor says. Unfortunately for footwear, there's the added association of a concern, or often a concern, for aesthetics. And I found this study interesting by Van Etten, describing footwear being a visual representation of the disease, being a reminder to the patient that they have something wrong with their feet, with themselves, and the footwear, the orthopedic shoes, being a reminder and creating a deterrence from the patients being compliant with their wear. And so it's no surprise that the patient acceptance of the wearing of the shoes and consideration of the shoes' appearance and their ease of use are very significant in terms of their level of utilization and consequently their potential effectiveness at reducing the likelihood of ulceration. Interestingly, no surprise, study here showed that people who have wounds and who are healing wounds and have been prescribed offloading devices or therapeutic shoes to prevent recurrence of devices wear them less than they should. And interestingly, when this was studied with closer examination, one of the reasons why people don't wear their offloading devices or their therapeutic shoes as much as they could relates to the fact that there seems to often be the perception that steps taken outside are more risky than steps taken in the house. And this is unfortunate because elderly sedentary people tend to take a higher proportion of their steps inside the home than younger, more active people do. And so when they're not wearing their shoes for a greater proportion of the time, they are certainly putting themselves at increased risk. So in this one study here, patients who were found to wear their shoes 87% of the time outside were only wearing them less than half that amount inside. So patients prescribed therapeutic shoes need to be reminded and should have shoes that they know they will wear or agree to wear or will wear inside the house, often a different style, perhaps a slipper style. So there are people who study this, what's referred to as patient non-compliance, and I found it interesting to learn about the description of two different types of non-compliance, and we talk about this being, unintentional and intentional, and you can really relate to this if you think about things like COVID mask wearing. So unintentional non-adherence means that people are not doing what they should be doing because they don't have a full appreciation for the risk that they are at and the difference that the recommended treatment would have for them. So again, it might be, the thought as it relates to masks that, oh, this is masks don't make a difference, and so I'm not going to wear them. And the same would go with shoes. The same could apply for shoes, and so it's really has to do with a lack of understanding. And again, it might be the fault of the patient. It might be the fault of the prescriber not presenting all the information in an understandable way. And then, then there's something they refer to as intentional non-adherence. So these are people who say, yes, they understand what they need to know, and they are like not going to buckle their seatbelt. Why are they not going to buckle their seatbelt? Because the likelihood of them having an accident is very, very low, and the discomfort of wearing the seatbelt is more than they want to have to deal with, and so they're willing to take their chances. Okay, they're not taking their condition seriously enough. They think that they can get away with it, and if they get into trouble, well, it's just not going to happen to them. So again, they're weighing the consequences. They think they have the full picture, and they are deciding against taking the bait or doing what is understood, should be understood as being best for them. So when you think about patient non-compliance in that way, it helps. It can be helpful to better address that. So for patients who are unintentionally non-adherent, meaning they would do what is right for them if they had a better understanding. And again, this can relate to footwear. Knowing that most people who have diabetes and are at risk for ulceration are not wearing shoes that are appropriate for them, whether it be the style or whether it be the fit. This can be addressed with regards to footwear by making sure that the risk that the patient is at is clearly understood, and that's where having some of those statistics that we went over earlier can be useful. So again, making sure that they know that when you have a patient who has developed a wound, that they are, even after it's healed, there's a 50% chance that that problem will recur within a year, and that there is a 20% chance of the of an amputation occurring when they develop a wound, and that there is and really scare them by letting them know that there's a 5% chance, a 50% chance of them not even being around in 5 years. Again, scaring them can be helpful when delivered in the appropriate way. Speaking in a way that is understandable, slow and non-technical. Having literature to be able to provide to the patient. This we talk about the health literacy, okay? Helping them to understand their condition, and very significantly having someone there with the patient who gets the message, who can be your ally in communicating that message. Okay, when people are giving you a hard time, it can be more challenging when they're pushing back. Sometimes this can be illogical, and it is really very important to get to the bottom of why they're pushing back and help them to have a better appreciation of the consequences were they to develop a wound, and the impact that it would have on the people that they live with, and the potential impact on their own independence and quality of life. Okay. So there's a radio show podcast called Freakonomics, and that show is entirely based on this concept that is described in this book written by Nobel Prize winner Richard Thaler called Nudge. And so nudge theory is based on being able to change people's behavior by nudging or pushing them gently in the right direction at very specific times. So again, creating change in a very unobtrusive yet effective way. And so and one of the classic example of nudge theory was the concept of how to help people save for retirement. And they found that there was a tremendous difference in providing a program to employees that offered to have regular deductions from people's paychecks and to save for retirement. And there was a tremendous difference if that program was presented in what's referred to as an opt-in, meaning you have to check the box to be in the program, had a much lower rate of enrollment than presenting it as an opt-out, meaning that people were automatically signed up for the program, but they simply would need to check the box, uncheck the box, in order to avoid the deductions from coming out of their paychecks. And so again, this was an example of a nudge to encourage savings for retirement in a way that was, again, straightforward, not misleading. It was easy not to participate in it, and it was related to a behavior that the person for whom it was subjected to the nudge knew was in their best interest. Okay, and so very much this type of scenario could be applied to taking the steps that are necessary in order to avoid diabetic foot ulceration. And it's an exciting time in that there are examples of nudge therapy and technology being applied all around us now and very much applicable to the treatment of diabetic foot ulceration. And a few examples that you might have seen out there now. There's a picture of a what's referred to as a smart boot, or by a company called Modus Sensoria, and includes sensors in it that monitor patients' compliance with wearing the boot and pressure on the bottom of the foot, and so can send reminders to the patient and to the doctor when the patient is not wearing the boot. The next picture shows some sensor-embedded socks. There's a company called Siren. Again, that has temperature sensors based on the understanding that plantar ulceration is an inflammatory event, and that prior to the foot ulcerating, there is an increase in the foot temperature. And by detecting the increase in temperature, it should be possible to intervene, reduce the plantar pressure, plantar irritation, and head that ulceration off. On the bottom right, there are sensors made by a company called, custom insoles made by a company called Orpix, also incorporating sensors that are able to detect plantar pressure and temperature and patient compliance. So again, be able to provide feedback to the patient with about the state of their feet, whether they are okay or whether the temperature is increased, and relate that also to the amount of steps taken and how much the insoles are being worn. Compliance is as simple as showing up on people's wristwatches now. So things like Google, apps like Google Fit that can be on people's smartphones or Apple Watch are providing feedback like heart rate and activity for free. So people are getting more and more accustomed to being provided with information about themselves, about their health, about their activity, and this type of information is is going to become increasingly able to be leveraged to improve people's health and to avoid health consequences. Another an organization that I'll speak a little bit more about is called Walk with a Doc, and again, and I think it does a great job at promoting healthy activity of walking, and plays on the concept of how much healthier people would be if they simply adopted the CDC recommendations of walking 30 minutes every day. So with regards to wound healing and boots and sensors, patients can think that they are doing a great job because they wear the boot most of the time. But if they are needing to heal a plantar wound and they wake up in the middle of the night and they take a few steps to the bathroom, those few steps might be all that's needed to set the wound back. Patients tend to variously underestimate the number of steps that they take, particularly indoors, and these are the concepts that work against the success of even the best, most skilled practitioners. So the psychology of wound healing very much involves patient feedback, and each of these different types of devices are developing their own platforms and figuring out the kinds of messaging and how much messaging is too much to create an annoyance and turn people off from wanting to take it seriously enough versus, providing enough messaging to motivate change, to perhaps put that boot on because you're not wearing it enough, or not take as many steps, or decrease the pressure on the bottom of the foot so that you can get that temperature down. This is the psychology that is right now being developed that I'm sure is going to result in our having better patient outcomes. COVID has accelerated the adaptation of this type of approach to care, which is referred to as remote patient monitoring. So remote patient monitoring is simply a way for doctors, for health professionals to keep tabs on their patients without having to see them face to face, and so entails some type of electronic device that monitors a physiological condition and provides display of the patient's state, both to the patient and to the physician, and can provide information about the things being okay, and even more significantly, can provide alerts when things are not looking good, and red type alerts when things are looking bad. So again, the concept is called remote patient monitoring. This applies to all sorts of physiological conditions. And so some of the attributes of remote patient monitoring play into some of the psychology that can be used for improving wound healing. And again, it's giving patients the direct communication about how they are doing, and objectively with the goal of improving their adherence to using the off-weighting therapies that are being applied to them. Okay, so some suggestions on how to improve patient compliance with whether they're wearing an offloading shoe or offloading boot is, again, to make sure that they are instructed on both the seriousness of their condition and the instructions for use, with a caregiver, with someone with them, someone who can help them. I can't tell you how many times patients are dispensed devices. The doctor puts it on or the assistant puts them on, but all these Velcro straps and these clips can be very confusing to someone when it comes time to have to put it on themselves. So it really is very important that patients understand and their caregivers understand how to take these things on and off when they have to, so that they are applied properly. It should be a given that patients who are prescribed shoes and who are encouraged to be wearing them whenever they are walking are also prescribed or recommended to get some type of supportive, accommodative shoe that they will wear all the time in the house. Okay? Socks don't cut it. Socks are better than nothing, but walking in socks doesn't provide the plan of protection that is necessary and is certainly also contributory to increasing the risk of falls resulting from slipping. So patients need to, again, be reminded of how much walking they actually do indoors and the importance of having protection on their feet for walking inside the house. So you're going to increasingly hear more from the first two companies that have come into the podiatry market place. Again, this is the Siren socks and the Orpix insoles, and they both are addressing the same thing with regards to preventing diabetic foot ulceration by monitoring foot temperature. And they have both developed very effective and increasingly easy to use interfaces, making it easy for the patients to connect the devices to the internet in a way that provides feedback to the patient through a digital device, as well as communicate with the doctor's office to send reminders when a red signal is transmitted, indicating an increased temperature and perhaps a intervention needed to decrease the inflammation by decreasing the pressure and decreasing the chance of ulceration. So I encourage you to become familiar with both of these types of devices because they have both been demonstrated to be effective, and patients will have preferences. There are going to be people who would rather wear socks and not have to deal with wearing, switching insoles between their different shoes. There are people who are going to prefer insoles to socks. So I encourage you to learn more about these and also learn more about how these devices tie into Medicare's new remote patient monitoring program. Medicare has finally gotten behind, again, this idea of the value of providing preventative care. And this is simply based on demographics. They say that demography is destiny. And the proportion of people turning 65 and becoming covered by Medicare, the cost associated with that is simply literally not sustainable with the current fee-for-service type model. And so Medicare knows that it has to promote programs that show promise with regards to preventing the decreasing the likelihood of these $10,000 ulcerations, these $50,000 amputations. And so if there is technology out there that can help to reduce these costly consequences, they are now on board with that. And the codes that were recently introduced with regards to the with regards to remote patient monitoring support this. And just briefly, the codes associated with remote patient monitoring cover both the providing of the device and educating them on its use, as well as a monthly billing that's possible for both the transmission of data kind of like your cable subscription, as well as communication with the patient about their condition based on an interpretation of that data. So being able to provide some kind of ongoing communication is now reimbursable. So you can be, as physicians, you can be compensated for your providing patients with a device, and that device might be a glucometer, that device might be a blood pressure monitor, that device might be something to measure pulse oximetry, that device could be something that measures the temperature of people with diabetes who are at risk for increased ulceration. The billing for these devices, provided the patients choose to use them and are wearing them, and the device is sending data on an ongoing basis, offers reimbursement to the practitioner of over $100 per month. So as long as the patient is wearing the device and the device is transmitting the data, and the practice is communicating with the patient by receiving the data and providing some type of communication, which is billed in increments of 20 minutes, reimbursement from Medicare could be in the $100, $120 per month range, so long as the patient continues to participate in the program. I mean, I think that this is the type of creates an opportunity for ongoing maintenance to ensure that patients continue with good behavior. Okay, and I think that such a program is absolutely complementary to the wearing of diabetic shoes, and the role that they can play in helping to helping patients to develop diabetic foot wounds. So remote patient monitoring, again, is a relatively new program, and when it was first introduced, there was actually a fairly low rate of adoption. It's still relatively new, and it's still not broadly has not been broadly implemented. But when it was first introduced, the reimbursements were much lower. And very significantly, recently, Medicare changed a rule. In the beginning, when it came out, Medicare said that the only way that a doctor could be paid for dispensing or covering a patient with remote patient monitoring would be if the doctor, him or herself, was providing the minimum of 20 minutes interactive communication with the patient. That was really prohibitive. I mean, it's one thing for a busy doctor to stay in touch with patients on a monthly basis if they're trying to do 3 or 4 patients every month and spending 20 minutes. But in order to cover all the types of patients, the hundreds that may be in a practice, it was necessary. It was necessary for this type of responsibility to be delegated, such that the patient could be cared for not under what's called the direct supervision of the physician, but rather under the general supervision. So this responsibility, this communication, this monitoring of the patient data could be done by someone employed by the physician and did not have to be by the physician. So again, they say there, the data monitoring may be performed by the physician or by a qualified healthcare provider or by clinical staff. That change, which just happened a year or so ago, is very, very significant. Okay, so in subsequent presentations that I'll be doing with DocStrap Pro, I'm going to be talking in much greater depth about both how the remote patient monitoring program works, and very significantly speak about suggestions and ideas on how to best implement this type of program into a very busy practice. Okay, just a little bit more, and again, very much relating to COVID. is an appreciation for, I think it needs to be an appreciation for the significance and the prevalence of depression that occurs in the elderly, and its impact on the quality of life. People who have limited mobility tend to be less able to take care of themselves, and there's a vicious cycle there. People who are inactive tend to not take as good care for themselves, and their health declines, leading to further depression and lack of well-being. And the important thing is to get into front of this, and this is where maintaining an active lifestyle, regardless of patient's age, is really so important. And this brings me back to the organization called Walk with a Doc, which encourages physicians to be role models to their patients, to make it part of their communication. You know, the Sports Medicine Association speaks to the concept of exercise as medicine. And one of the good things about getting older is that the amount of exercise that you need to do to maintain your fitness becomes less and less. Again, the CDC recommendation for moderate activity is 30 minutes of moderate to brisk walking per day. And that might not sound like a lot to a young active person, but it is unfortunately a lot more than most people do. So Walk with a Doc, I encourage you to look it up, simply based on the idea of the physician being a role model to their patient and committing to leading a community walk for their patients on a monthly basis. Simply say that on the second Saturday of every month, we're going to meet in the park, and they start out with a little health talk, and then just go out there for people walk at their own pace for 30 minutes. And it's so complementary to everything, to the messaging associated with prescribing diabetic foot care. I like the concept of prescribing footwear for the purpose of enabling people to be able to walk and maintain their healthy, active, independent lifestyle. Another expression that I use with patients when dispensing shoes is the idea that they should wear them out. Sometimes people have the wrong idea. They are upset when they come back a year later and said, "Oh, this shoe is completely worn out." I say, that's good. Doesn't mean that the shoe is defective or not poorly made. It means that it's being used. There's no point in keeping the shoes in the closet and saving them for special occasions. So the concept is here's the shoes, wear them out. Okay. Again, getting your patients to commit to a walking program where they will have a partner, where they will be with a community, has all sorts of transformative effects with regards to improving their health. And so doing this in a community is a very powerful way to implement such a program. And so in this talk, I hope I have provided you with a better understanding of some of the biomechanics that are associated with the development of diabetic foot ulceration, and why simply making a good orthotic or a good shoe, or providing a good shoe, is not all that it takes for patients to be to avoid developing ulcers. Good health and independence and mobility is very much a complicated process that entails patients' own self-care, responsibility, commitment to protecting their feet, and that a virtuous cycle can be created where if they can keep their feet free from ulceration, they are able to be more active, they're able to have a better state of mind, and they will be better motivated to pay the price, to do the things necessary to keep that type of good thing going. There is technology that is coming out, and there are payment models that are being introduced that are supportive of this approach to care. And I'm very encouraging to podiatrists to be aware of these changes and to actively embrace them, to make them a increasingly important part of their practice and their patient care. And so with that, I'd be happy, Nick, or Greg, to take any questions.
Sounds good. That was fantastic. Thank you very much, Dr. White. We do have some good questions that came up through the chat and the questions portal. If you flip to the right, I'll just start with the chat section first, and we'll just kind of go one by one through here. The first one was from Dr. Hardiman. The cost of amputation has increased dramatically since the study that you cited in 1994. I know sometimes trying to find just a study to give some good data, but there's obviously more recent feedback heard from people. If you want to just kind of speak to that and provide some additional background around that, anything you wanted to share?
Well, it's certainly that's from 1994. And 10,000 sounds like a lot. So for a wound. So I don't know the specific study that's being referred to, but if Dr. Hardiman can share that, we could certainly put that out there.
Sounds good. Kind of jumping in, actually another one from him. So the RPM code required at least 16 days of data sent electronically. Is that correct?
Yeah. So the specifics for being able to bill on a monthly basis is that physiological data be transmitted at least 16 out of 30 days. So when using a remote patient monitoring device, there needs to be a system for tracking that data. And that's the type of documentation that would be fair game for Medicare to ask for, should there be a review of the justification of the charge.
Gotcha. Moving to the questions tab, and if anybody has other questions, feel free to jump in here as we go. There was a question from Dr. Jerome Leff. What is the doctor's costs for the inserts and monitoring system?
Each company has their own model, and it might just probably best just to direct the cost questions, but because I think there are different options with regards to services. So there's a cost from these companies for the device themselves, and then there can be a cost associated with providing of the services for the ongoing patient communication, as well as the transmission of information, of data. But the Medicare reimbursement is, use the example, about $120 per month. And I think that with any of these companies, practitioners can expect to be able to earn in excess of $500 per patient per year. So if you do the math of a minimum of $500 net after the cost of the service and the product, $500 per patient per year can add up to substantial practice revenue.
Absolutely. Thank you for jumping in on that one. Another one, kind of a follow-up here on different systems. The podometric system, stepping on the mat for 20 seconds daily, and the temperature of the feet being recorded. The VA, in some of the chat feedback here, loves that. I wanted to see if you wanted to speak to that part of it in identifying the ulceration patterns and just good readout.
Yeah, I think that making utilization of the technology easy for the patient is fundamentally important, and without even speaking to the accuracy of the monitoring of the accuracy, call it, of the thermometer. If the patient doesn't use it, it doesn't have any benefit. So I think that certainly the ability for a patient to simply, in effect, like stand on a scale, stand on a mat each day offers tremendous ease of use. It's kind of like Weight Watchers, weighing yourself every day and recording that makes accountability very simple. And all of these companies are working on improving both the ease of use with regards to sometimes having to do with having the device needing to be charged, as well as the simplicity of these devices transmitting the data. So I make the analogy to your cell phone. I mean, people remember to charge their phone every day because they want to be able to use it the next day. With regards to these types of devices, if they are not prepared, if they are not charged and don't work, it does not have the same perceived consequences as a person's phone not being able to be used.
Yeah. Thank you. Another one here, wrapping up the last couple pieces here. You hit on this earlier a little bit. I think the question was asked kind of right before you hit on it, but I just want to give you the chance to follow up on it again, specifically talking about people and non-compliance with the footwear. People only wearing them 50 to 60% of the time, and then you talked about when they come inside, you have having a therapeutic slipper.
Yeah,
that's kind of more used for in the house. I just wanted to see if you had any more kind of feedback or thoughts around how often that really is necessary, kind of your approach to recommending that, if you had any other insight kind of around that when that's a sensitive.
The patient should never be walking barefoot. And there is that lack of with neuropathy is combined with poor vision, combined with poor flexibility, all contribute to patients developing, scratches, blisters, and without the ability to perceive the problem or feel it. These are the types of problems that this is where every big problem, as I say, every big problem starts with a small problem. And so, patients should not go barefoot at all, and get back to that same ease of use. So a slip-on style is sometimes easier to use, provided it doesn't provide a sloppy fit. You don't want to cause a tripping accident. So it needs to be, comfortable, protective, easy to use. These are the complicated factors to take into consideration. But simply wearing thinking that the same shoe that is going to be worn outside is going to be appropriate for in the house, frequently misses the mark.
Thank you for follow up on that one. Some more questions are coming through, so thank you everybody for keeping them coming. Following up on the RPM code,
okay,
and the 16 days of data, how much time per day?
The time per day is not specified, so it needs to be. There needs to be data. Some of this has been introduced in a rather generalized, not very specific fashion. So there needs to be one of the terms in there is that there is continuous monitoring, and so it's not specific whether the data you can take someone's temperature for 13 seconds, or whether you need to take their temperature for 23 hours a day. It's not clear. What's described is continuous monitoring, and but again, that's relative. And so I don't want to confuse things but I can't be specific because the definition is not specific.
Okay. Very good. How about what are the findings needed to do siren socks?
Okay, so I'll just fall back on a general Medicare concept which is based on the presumption by Medicare that as physicians we are both intelligent and honest, and by that I mean that provide Medicare will often accept justification for payment when there is documentation of medical necessity. And so these RPM devices are justifiably billed when there is a physiologic condition that is being monitored. So and there are some other specifics, like, for example, the device has to be FDA approved in order to be a billable, the transmission of data can be billable. But bottom line is that there has to be a reason going on for wanting to monitor the temperature of the patient's feet. And so certainly diabetes and increased risk for ulceration, particularly if there is a associated secondary risk factor like a structural change like a bony prominence or PVD or neuropathy, support that medical necessity and the use of a temperature monitoring type device.
Okay.
Okay.
So pain, burning, numbness, all of that would qualify?
Yeah, but I think those are secondary conditions. There should be there should be, pain because of neuropathy, if that's the case, or pain associated with PVD. So, I mean, pain because there's a nail in your foot doesn't mean that you need to monitor the temperature of the foot.
Yeah. Thank you. Yeah, and so as far as questions, there's been a couple different questions about getting the actual socks, getting the actual orthotics, all the different variants to kind of get this, the actual products themselves. You can definitely reach out to us. For anyone that's in the chat or in the webinar here that's not already a member of DocShop Pro, it's free. You can register for free access to the site. We can definitely get you connected with Dr. White. We have options there. And then, of course, if you already have login credentials, you can look up some of the options there and then reach out to your rep. They can follow up to get some additional information if you'd already have what you're looking for there. Or you can, of course, engage directly with Dr. White.
My pleasure.
Let's see. I think we got just about everything here. I just want to make sure there aren't any big questions that we still didn't get to at all. I saw a few more coming in.
Hey, what is the finding?
I think that is it.
All right. And if people think of anything and want to email them in for them, I'll be sure to get right back to them.
Thank you.
And again, we're going to be doing more of these lectures on a monthly basis and covering with greater specificity and practicality essentials for improving a shoe fitting program and implementation of remote patient monitoring. And I'll get into greater detail about the use of these different types of remote patient monitoring types devices, and in greater detail of the Medicare compliance rules and regulations and documentation associated with their utilization.
Yeah, and thank you everyone for joining. We really appreciate your time too. We'll be posting a replay of this event for anyone that joined late, maybe missed the beginning or knows of other members of your team that would want to watch. We'll be posting the replay immediately after this. It'll be available. We're excited to work with you, help you and your team however we can. Be safe and have a great night.
Okay. Thank you.
Thanks again, Dr. White.
Bye.